Hello everyone, my name is Dr. Nisha Khot. I am the President-elect of the Royal Australia and New Zealand College of Obstetricians and Gynecologists, and I'm going to talk today about simulation in healthcare. In Australia, we usually start all of our presentations with an acknowledgement of country where we acknowledge the traditional custodians of the lands on which we work and pay our respects to elders past, present and emerging. My presentation today will cover the history of simulation. We'll talk about simulation in obstetrics as well as outside of obstetrics in things like gynecology and ultrasound. And we'll touch a little bit on the future of what simulation might look like. So what is simulation? Simulation is basically a model that mimics the working of an existing system or a proposed system, providing evidence for decision-making by being able to test different scenarios or process changes. It's something that we have found very useful in healthcare. But did it just come about recently? Actually, if we look into history, all the way back in the 6th century, Lao Tzu was talking about automation machines. Hippocrates mentions simulation in as far back as 460 BC. And our own Sushrut Samhita is the oldest written evidence of simulation in healthcare. And what was the reason for simulation? It was partly driven by religion. The Catholic Church did not permit dissection of human bodies, and so wax body parts were created for the study of anatomy. Over the years, simulation progressed, and in the 1800s, Georg Heinrich had his thesis on simulation, which was a short likeness of devices for practicing obstetric skills. So this is where simulation enters obstetrics. And then Galli designed a glass uterus for midwives and surgeons to train during childbirth. Simulation has a long history. And why should we actually use simulation? Simulation works really well to learn technical skills like surgical procedures, whether they are open surgical procedures or laparoscopic procedures. Also for obstetric procedures like shoulder dystocia, for example. But really important is the non-technical skills, the teamwork, the communication, the making sure that we manage our resources well, that we prioritize and triage all the things that happen around us when we are in a busy labor ward. The technical skills are best learned when you have simulation equipment like mannequins. They're usually not scenario-based and they focus on the individual skills. So, for example, when you're learning how to deliver a shoulder dystocia, it's the individual learning how to perform the various maneuvers that help with the shoulder dystocia. The debriefs are also individuals. The technical skills can be used in objective testing in that OSCE kind of scenario, and they can be used to learn new techniques. The non-technical skills, on the other hand, are usually clinical scenario based, and they are focusing on team participation, on optimizing teams. Generally, the debrief also happens with the team, and the assessment is also of the entire team rather than just one individual. These kind of simulations are good when you're trying to introduce a whole new system. For example, if you're moving into a new hospital, trying to simulate and finding out how an emergency might work in this new hospital needs this kind of a simulation scenario. Why simulate in obstetrics? We know that obstetric emergencies are relatively uncommon. When they happen, they're time critical and they require specific expertise and a team to manage them properly. If we look at inquiries into maternal deaths, whether they have been done in UK or Australia, they consistently show that there are recurrent issues that lead to potentially preventable deaths and morbidity. And all of this has medico-legal consequences. Some of the recurrent issues that have been identified include a failure to recognize an emergency, a failure to escalate in a timely manner, inadequate communication, and ineffective teamwork. So where is the evidence that simulation makes a difference? Most of this evidence comes actually from Prompt Maternity, which is a UK-based program which has spread around the world. And the research that has been done in this field shows that actually it does reduce maternal deaths. It reduces the time for delivery in an emergency cesarean section. It reduces HIE, hypoxic ischemic encephalopathy. It reduces the likelihood of low APGARs at birth, reduces the likelihood of getting a brachial plexus injury or cerebral palsy. And of course, all of this has financial implications because there is reduced litigation costs. In Australia, there is a mandatory CPD requirement, which is required to maintain your specialist registration. And this is via the College of ONG as well as the Australian Medical Council. All healthcare providers who work in maternity care and provide sort of that acute labor ward, birth suite kind of service are required to have annual maternity multi-professional simulation-based scenario training. We are also required to have annual basic life support training. And then in addition to this, individual states can decide that they want something more, and some will decide that they need to have all of their clinicians trained in basic neonatal resuscitation. Some will insist on advanced neonatal resuscitation, and some will insist on annual skills-based simulation training. So the difference here is the multi-professional training is the team-based training, whereas the skills-based training is the individual clinicians doing skill-based training. If you think you want to set up a simulation program, the best thing to do, first of all, is to identify the issues you face in your unit, from the emergencies you have had, from perhaps poor outcomes you have had, either maternal outcomes or neonatal outcomes. Based on that data, you can then design your scenario so that it is useful for your team, because you have identified the problem that exists in your team. It might be that you have a very high PPH rate. Once you have identified that, then you want to look at what is our PPH protocol, design a scenario, and then run that scenario with the teams who work together so that then you can finesse how PPH is treated in your unit. And you can do that with any problem that you identify in your particular unit. When you prepare for this, remember that you will need to design and test the scenario before you actually use it in the simulation. Make sure you have appropriate equipment. You may or may not want to use an actor for that scenario. Make sure you have drugs available. Moulage is basically trying to pretend there's blood. So in some situations, you might use blood that has expired and soak, maybe sheets in blood so that it looks real when participants are doing the simulation. On the day, it's always good to be prepared for the unexpected. You might find that actually there are so many emergencies in your unit that all of the people who have come to train in simulation need to go off to work. So be prepared for that sort of thing. It's good to alternate between skills training and scenarios, because then it gives everybody a break. It gives you the opportunity to do different things. Sometimes it's also good to just have an icebreaker, something fun, something that everybody can, do without trying to think about, oh my God, this is something that I'm doing clinically. And we use things like building a tower out of blocks, or, trying to move a stick by a whole team, making sure that it gets into the right positions. There are many such things, and you can try whatever works best for you. Really important to allow time for debriefing at the end, because the debriefing is where all of the issues come out and where you can actually discuss how you can change the way you do things in your unit. So what is this debriefing? Basically, it is a practice of reflection, of learning what you did well, learning what you didn't do so well, so that you can change that in your practice. Really important to establish a safe space. People won't speak up if they feel like they may be made fun of, or if they feel like others will gossip about the fact that they were not good enough. So as the person running the simulation, it's really important that you create that space where people feel like they can say the things that they want to say, that they don't feel like they're being judged. Structure your debrief the way it works best for you. Generally, it's good to ask people after they have done a really, complex scenario where somebody has had a big PPH about how they feel, because that just helps lower the tension. Then you can move on to analyzing how things went, what were the things that were done well, what were the things that could be done better. And in the end, summarize all of the discussion so that people take home those key points and learn from the experience. These are really good ways of identifying gaps in knowledge and performance and addressing these. Choose different frameworks. There's lots available in the literature. You don't have to stick to one. You can mix it up, keep it interesting. This is just some photographs from simulation scenarios that we do. One of our teams has a bus, and we take all of our equipment with us, and we go to the little rural units and we run simulation training in the units. The photograph in the middle is of us doing a fun activity, building a tower. It's a way of getting to know each other. It's a way of diffusing the tension. It's a way of having some fun while you're also studying. How about non-obstetric simulation? Now, simulators are used very commonly in ultrasound training. They can be used in open surgical training, vaginal surgical training, and laparoscopic surgical training. Specifically, things like cervical cerclage, which is not something that you might do very commonly. It might not be something that you do outside of the emergency situation, so it's good to practice it. Similarly, with internal iliac ligation. And of course, the newer versions are robotic surgery simulation. What does the future look like? Possibly fully integrated simulation. There's lots of simulation happening in research, and there is lots of research happening in the simulation space. So there's a nice synergy of that. And of course, the future will probably hold a whole lot of augmented and virtual reality and the use of artificial intelligence. But I think for our purposes, it's really important to remember why we are doing simulation. Especially in obstetrics, what really makes a difference is when a team works together, when everybody brings their skills and is able to use those skills and is able to voice what they're thinking. And so although we have lots of fancy mannequins and AI and things like that, ultimately what really works in obstetric situations is getting your team together, getting your nurses, getting your midwives, your junior doctors, senior doctors, all coming together and running those scenarios so that we all learn from each other, we all feel comfortable as a team, and we know our strengths and weaknesses. Thank you very much. I hope you enjoy the rest of the conference.
Thank you so much for that informative lecture, Dr. Nisha. Simulation is very important in today's day and age, and you've touched upon every single point very well. Thank you so much.